Hello, everybody, and welcome to our TIF talk. Today is not Tuesday, it is Thursday, so a little bit unusual for us to be on a Thursday, but we're very excited to have our special guest tonight. We have a thoracic surgeon and a GI tonight, so hopefully you'll get some new tidbits today that you wouldn't have normally got from our regular TIF talks. But before we start, I do want to remind everyone this is a live event. So if anyone has any questions at any time, please feel free to type it into the comment section, and we are going to do our best to answer all of your questions. So with me tonight, I have Lynn McFadden. She is also with Endogastric Solutions, and we have our two special guests. Have you here. Fantastic. You're welcome. Thank you. So before we start, I do want to give you a little background on our guests tonight. Dr. Skef is a board-certified gastroenterologist practicing at Loma Linda University Medical Center in Loma Linda, California. He attended medical school at Weill Cornell Medical College, internal medicine residency at St. Elizabeth's Medical Center, Boston, fellowship at University of Pittsburgh Medical Center. Welcome again, Dr. Skef, and thank you for being here with us tonight. You're welcome. And Dr. Lee is a board certified in general and thoracic surgery, practicing also at Loma Linda University Medical Center in Loma Linda, California. He attended medical school at Drexel University College of Medicine, surgery residency at Donald and Barbara Zucker School of Medicine at Hofstra, Northwell, and Cardiothoracic and Robotic Thoracic fellowships also at Hofstra, Northwell in Hempstead, New York. Welcome, Dr. Lee, and thank you for being here with us tonight.
Glad to be here. Thank you.
Thank you. So we're going to go ahead and start with the program, and we generally start asking, what is GERD? What could potential patients that are suffering from GERD, what are the types of symptoms that they would feel if they came into you complaining about GERD? Whoever wants to go first.
Go ahead, Dr. Scott.
Yeah, so, GERD or gastroesophageal reflux disease is a common complaint, something we see commonly in GI, but also in just internal medicine specialties. And gastroesophageal reflux disease is in the name of itself. It's reflux of gastric content that causes bothersome symptoms for patients. The typical symptoms that patients will complain of are usually heartburn, and the other common symptom is regurgitation. But GERD can also manifest in other ways. Patients may have a chronic cough, patients may have chest pain, and a whole multitude of other symptoms that can also be attributed to GERD.
Fantastic. Thank you. Anything you want to add, Dr. Lee?
There are a lot of people who suffer from this and don't necessarily know that it's a big issue for them. A lot of times, patients will take a lot of medications, all different kinds of medications, to see if they can get relief of their symptoms. And sometimes they feel like it's good enough, but we typically, a lot of people experience reflux, but not everybody presents and knows that there are different solutions to helping.
Yeah. We often have patients, as you had mentioned, typical symptoms versus atypical symptoms. There's sometimes patients go into the ER or ENTs complaining, and what they're finding out is they're actually suffering from GERD. So I'm glad you had mentioned that. What do you normally recommend to patients, kind of like the initial phase, to help manage their GERD or their chronic acid reflux?
For me, the two types of medications that the patients typically go on are either the H2 blockers or the proton pump inhibitors. Those are usually the first-line medications. But patients, a big part of it is also lifestyle modifications as well. different spicy foods, smoking. All these posture can even add to your reflux. So knowing what their habits are and modifying them, and then adding medication on top of that, and see how they respond to that.
Right. How about you, Dr. Skef? Anything to add to that comment?
Yeah, no, that's pretty much it. I mean, the other main thing that I typically counsel patients on is weight. There's good data supporting that for every increase in the patient's BMI, that their incidence of reflux symptoms goes up. So that's another important lifestyle modification that we try to counsel our patients on as well early on when they're first seeing us for reflux.
Fantastic. Thank you. What options currently are available to treat GERD? I mean, you did mention, Dr. Lee, the medical therapy. What other options, aside from lifestyle modifications and activities, to date, what are the options that are available for GERD?
So, yeah, lifestyle modifications, which you mentioned, medications, and then there's endoscopic therapies, meaning things that Dr. Skef can perform, and also you can go to a point where you're doing surgery or a hybrid of the two. So, I'm a surgeon, so obviously I perform surgeries to help fix the reflux, where Dr. Skef can do other procedures with his endoscope to help with the reflux as well.
Yeah. Anything to add, Dr. Skef?
Yeah, no, I agree with that. And, typically patients that have had reflux for a long time, if they're kind of in the more advanced stage of their gastroesophageal reflux disease, classically would be offered a surgery. And so this is where a combined surgery approach is something that we are now excited about offering for some of our patients.
Fantastic. So, yeah.
I did want to mention something. I'm sorry.
Don't be sorry.
I think that one of the important things to understand that obviously the patients can get reflux and symptoms, and that can cause just issues in their a patient's daily life. But long-standing reflux is also a risk factor for esophageal cancer. So at the more advanced stages of disease, the GI doctor, Dr. Skef, will be, if they develop changes in their tissue in their esophagus, they will need ongoing monitoring, just because that in the future could lead to esophageal cancer.
Yeah, thank you for mentioning that. It is Esophageal Cancer Awareness Month, the month of April. So I'm glad you did mention that. And I generally ask, what is the correlation from GERD to potentially Barrett's esophagus to potentially cancer? So do you want to talk a little bit more about that, Dr. Skef? The correlation between GERD or untreated GERD, really?
Yeah, so we know that chronic gastroesophageal reflux disease can cause irritation in the lining of the esophagus, and over time, the esophagus can try to remodel the lining and form what's called Barrett's tissue or Barrett's esophagus. And while this is a protective mechanism, it does increase your risk down the line of esophageal cancer. And so this is why patients with chronic gastroesophageal reflux disease with certain risk factors should be screened for Barrett's esophagus, because GERD, like Dr. Lay said, is not simply just a lifestyle disease, but also does carry important prognosis and risk factor for development of esophageal cancer as well.
Sure, thank you. And can you talk a little bit about the diagnostic workup that a patient would go through to determine whether or not they truly are suffering from GERD, and then B, could they be a candidate for one of these, anti-reflux procedures that you're talking about?
I'll let Dr. Skef. He does a lot of the diagnostic work for our patients, so he can speak to it better than I can.
Perfect.
Yeah, this is an area of interest of mine. I think most patients that present to us have been probably trialed on a medication already, and either they don't want to continue it for life, or they are not getting enough relief. So then we do undergo a pretty traditional standard workup for these patients. Typically involves an endoscopy, which is a sedated procedure with a camera to evaluate the esophagus and the stomach. we probably will take biopsies, and then we usually will also do a pH study at the same time. And a pH study allows us to measure the amount of acid reflux that's occurring over a certain time period. And that can give us a definitive diagnosis about whether the same patient's symptoms are actually from gastroesophageal reflux disease. Additionally, there are ancillary tests that we do like to order for these patients, especially for considering them for potential endoscopic procedure or surgery down the line. And these include manometry and an esophagram. So a manometry is a test whereby a catheter is threaded down the nose into the stomach. You're unsedated, and we do a series of swallows. And what we're trying to do is assess the function or the motor function of the esophagus, and trying to rule out any additional disorders that can mimic GERD. And an esophagram is an X-ray test where you swallow some contrast, and we take a series of X-rays, and we also are simply trying to assess the structure of the esophagus and evaluate for possible reflux and hiatal hernia. So that's kind of the typical test that we will order for patients with gastroesophageal reflux disease that's refractory or considering some sort of procedural or surgical option.
Okay, thank you. And Lynn, I do see some questions popping up, but maybe we'll go to the next question first, and then we'll let you get through some of the questions. Can you tell us a little bit about, we're here today to talk about the TIF procedure. Can you explain how does the TIF procedure work, and maybe what's the comparison of that versus, the traditional Nissen fundoplication or whatnot? And then we'll talk about also the hiatal hernia, but let's talk about TIF first. Dr. Skef.
Yeah. Dr. Skef, go ahead.
Oh, I was going to let the surgeon answer that one.
I can answer the first part, sure.
Yeah. No, I think the TIF procedure is an exciting procedure because as a gastroenterologist, we typically see patients that have undergone surgery, like a Nissen fundoplication is typically the type of surgery or a variation of it. The TIF attempts to recreate a fundoplication endoscopically, but the difference is it's trying to create a more physiologic omega-shaped valve. And so we're trying to recreate the natural barriers for gastroesophageal reflux disease, as opposed to just kind of wrapping the stomach around and creating what we call a high pressure zone, which can come with side effects, typically difficulty swallowing food and or sometimes issues with bloating and inability to belch. And so the TIF procedure takes on these simple principles of fundoplication, but tries to create a more physiologic type barrier. And therefore, it is kind of getting the beneficial effects of a traditional fundoplication, but hopefully minimizing the potential long-term side effects.
Perfect, thank you. And we Dr. Lee's part of this collaboration between the two of you is very important as well. Can you talk a little bit more, Dr. Lee, about how the hiatal hernia repair, impacts the outcomes of fixing that with the TIF procedure called the CTIF, if you will?
Sure. Well, I'll just start by explaining what a hiatal hernia is. You have a diaphragm which sort of separates your chest from your abdomen. And normally, your stomach is in your abdomen, and you actually have some part of the bottom part of your esophagus that's still in your abdomen in a normal anatomy. Because there is positive pressure in your abdomen and sort of negative pressure in your chest, the diaphragm can widen, and what happens is the stomach starts to migrate up into the chest. And because of that, your reflux barrier just doesn't work anymore because it needed to be intact with the diaphragm and the sling fibers that create the lower esophageal sphincter needs to be all in the same place. But once it's sort of migrated up in the chest, everything opens up and you have free reflux up and down. So when there's a hiatal hernia involved, me and Dr. Skef have combined to do these procedures where I will start in the abdomen with surgery, free up the attachments of the stomach in the chest, bring it back down, and then tighten up the diaphragm again to make it tight like it naturally should be. traditionally, before I did these procedures with Dr. Skef, I would do the Nissen fundoplication. Like we talked, basically it's a 360-degree wrap around the top of the stomach around the esophagus. But as Dr. Skef mentioned, there are definitely patients that have unwanted side effects because of this, whether it's the inability to belch, gas bloating, dysphagia. Sometimes the wrap is too tight and patients can't swallow well. So there are a host of issues. So with the combined TIF procedure with the hiatal hernia repair, we've had great results so far with the patients that we've done. And one thing I wanted to mention is that after Dr. Skef does his portion of the procedure, I look at the fundoplication like, I cannot make it look as good as Dr. Skef can. It looks so good and it's amazing. It just, and the patients have all done well because of it.
Wow. Yeah, that's interesting, right? That's probably different for you being a surgeon, right? And always that was something you can fix, but that's fantastic. Thank you for sharing that. I am going to go pass it to Lynn because I do see some questions popping in. So Lynn, take it away and go ahead and ask the questions.
Wonderful. Thank you. Yeah, we do have a few questions in the queue. First, I wanted to ask you touched a little bit on the workup, just for patients who are wondering what that process timeline-wise looks like. Dr. Skef, what is the timeline from workup to potential procedural intervention if a patient is eligible?
It's a good question. I'm sure patients sometimes are frustrated with the delay in workup and diagnosis and surgery. Over here at Loma Linda, what we've been trying to do is after they visit with me in clinic is we try to do that entire workup, ideally in one session, at least the endoscopy, pH test, and the manometry. I try to schedule all three of those on the same day. The esophagram, we also try to fit within the same similar time window. And then afterwards, we give them a follow-up with me to discuss the findings and reiterate kind of the options. And if they decide to proceed with surgery or the TIF option, then we usually have them meet with Dr. Lay before we schedule that surgery. So that whole workup period happens in the space of probably anywhere from about 1 to 3 months typically after a patient's going to come to us for the initial consultation for that TIF operation.
Awesome. Thank you so much. We've got another question about what is the benefit of having both a GI and surgeon as your care team when you're a reflux patient? If you could speak to that a little bit.
Yeah, I mean, I think with not just this type of surgery, any type of surgery, it's really a collaborative and team effort. I depend on the findings that Dr. Skef finds with his workup to, we try to tailor whatever operation that we're doing to that patient. We talk back and forth, is this patient right for this procedure? Or is this going to help them? Do they have other findings that may not help them, and maybe this won't work? So as much as we're choosing patients to, for this procedure, we also look at them like maybe this procedure is not right for them and maybe they need something else. So that collaborative effort, having, two is greater than one, and in this case, especially in all facets of medicine, everyone's sort of working in a multidisciplinary kind of effort, and the results show that you have better outcomes when you have people coming from different areas, whether it's cancer related or here it's GI and surgery, GI surgery related. I think it's important just with that collaborative effort to get the best outcomes for the patient.
Wonderful. Thank you so much. Haley is asking, what is the correlation between a hiatal hernia and GERD? And would those patients be a good candidate for the TIF procedure?
Good, Dr. Skef.
Oh, yeah. So I think Dr. Lay kind of did touch on that very nicely about how once a hiatal hernia starts to develop where the stomach's starting to herniate through the diaphragmatic opening into the chest, you lose your natural barrier to reflux. And so then the larger the hiatal hernia, typically the worse the GERD. And if a hiatal hernia is caught early on, in other words, it's really like 2 centimeters or less, then potentially they can be an endoscopic only or TIF only option. But once the hernia has gotten large enough, then you really do need a combined approach with a surgeon to repair the diaphragmatic opening and bring the stomach back down into the abdomen. And then a TIF can be done at the same time and during the same operation to kind of shore up that lower esophageal sphincter and really kind of enforce that high pressure zone and try to limit any reflux.
Wonderful. Thank you for making that differentiation between the two approaches and that there are options for all patients. We have a question here that Wendy's asking, do adult asthma and GERD have similar symptoms?
Well, you can get reflux. People call it silent reflux, and the symptoms typically more present as like a cough. That's more of a typical reflux-related type of symptom. I'm not sure asthma is a thing. Is that something you've heard, Dr. Skef?
Yeah, I think Dr. Lays is absolutely correct that chronic cough can be due to atypical reflux or silent reflux. But asthma in of itself is a separate entity. However, I will add that asthma can be exacerbated or made worse by uncontrolled reflux. So there are patients that have both disease processes, asthma and reflux, and have been actually evaluated for these types of procedures or operations in order to better control their asthma, because the reflux can be an added insult or injury to their underlying asthma.
Right. So I guess the big message here is if you have symptoms, get checked, understand what's causing them, if there's anything more going on. So thank you for that. Kawali, I'm sorry if I'm not pronouncing your name properly, but he's asking, I had a hiatal hernia procedure done 4 years ago. Now I'm having issues again with what to do and what to eat. Maybe you could help give some general advice for this gentleman.
I think that with surgery itself, and it sounds like he had hiatal hernia surgery before, he or she, I'm sorry. There's always a recurrence can happen. You can have a recurrence of your hernia and start to get reflux again, get symptomatic. So I think more than sort of just trying to figure out what foods you can and cannot eat, I think you need to be reevaluated again to see if your hernia has come back. Because no matter if your hernia has come back, no matter what you eat or drink, you're still going to be symptomatic. So it's really important to see if everything if you had a niacin or whatever type of, if that's still in your abdomen, if things have migrated back up in the chest. There are different reasons for the operation to fail. And, working with both the surgeon and a GI person, you may need more studies, again, more manometry, more pH studies to try to figure out exactly what the issue is, because sometimes the surgery can break down or patients cough really hard and can break sutures. And so there's a whole host of reasons why you might be symptomatic again if you were doing better before. So that really should be evaluated by your physicians.
Yeah, great advice. When you start having those symptoms, it's always time to go back and ask your physician and talk to your doctor. So thank you for that. Andre, I think for now we have most of our questions answered, so I'll turn it back to you.
Fantastic. Thank you so much, Lynn. Doctors, can you talk about what a patient could expect, kind of before, during, and post TIF procedure and hiatal hernia repair? Dr. Skef, I'll let you go first.
Well, I think the workup we kind of mentioned briefly, and on the day of surgery, we typically perform this surgery together, and post-surgically, when we do the TIF operation, or even if it's just a straight TIF, which is just the endoscopic fundal application without the surgery, we typically admit them overnight for observation. And then once they are, cleared to go home the next day, they are expected to be on a modified diet for 6 weeks. There's a pretty rigorous diet that they're on. It's typically consists of, starting out for liquids for a couple of weeks and then slowly kind of reintroducing a more solid type diet. And then also there's some limited activity restrictions in terms of, not lifting more than 10 pounds for 6 weeks and, not doing any very strenuous activity. But typically it's that 6-week recovery period. We follow the patients very closely during that time period. Then afterwards, typically after that kind of recovery period, patients essentially they're back to normal. And actually, most patients will report to me that they just, it's like night and day with their reflux. They feel so much better. So that's the usual perioperative and post procedural time period and expectations.
I think one thing I wanted to mention is that sometimes post-operatively, the patients don't feel like things are going down well. And, part of it is that we just did surgery there and there's a lot of inflammation. And sometimes it can take a few weeks for the inflammation to come down and they feel like things are not getting stuck. So if patients, are worried that, they're not fixed or not better right after the surgery, we usually try to just let them know that, it's going to take some time for the swelling to go down. You had a lot of surgery there. Your stomach is back to, in the normal position. It hasn't been in for years. So your body's getting used to back to the normal, used to new valve and with all the inflammation. So it just sort of takes time and a tincture of time. So, and they usually typically get better.
Yeah. Is there any other things that is it different, the recovery, if you will, straight TIF versus TIF with C-TIF, if you will, concomitant procedure? Is the recovery the same pretty much?
I don't see the TIF, but if you add the surgery on it, you have abdominal incisions. So you just want to make sure, like Dr. Skef mentioned about the heavy lifting, no heavy lifting for a few weeks, just so that we can have the incisions heal. But typically there's not actually a lot of pain from I do these surgeries robotically. There's just really these small incisions over the abdomen. So usually there's not a lot of abdominal pain, but we still want to make sure that the incisions are clean and dry and healing okay. But if you're just doing just the TIF, then we're still following the same diet and everything. So it should be pretty similar.
Fantastic. And what about going back to work? We get a lot of questions about when can I go back to work? So I think people are quite surprised when they find out, oh, you can go back pretty quickly, as long as depending on what you do for work, right? Yeah.
Yeah, we try to individualize it. It depends on the patient and what they do. Obviously, if there are restrictions in what they do in terms of lifting for work, then obviously we do have to have them either reassigned temporarily to a desk appointment or maybe be light work during that time period. But typically, I have in my practice and with Dr. Lay, we've been giving them about a couple weeks to recover, and then they're usually back to work. And I think that they do very well after that. So that's been my practice so far.
Perfect.
I think generally, yeah, I give like a 2 to 3 week time frame just for some rest. But I tell patients, especially if they just have desk jobs, if you want to go back earlier and you feel okay, that's okay too. And if you need actually a little more time than 2 or 3 weeks, you need 4 or 5 weeks, that's okay too. Everyone's recovery is individual. Everyone has different needs, and so it's but average 2 to 3 weeks, but it can be plus or minus.
Yeah, I like that. Listen to your body, right? So I'm looking at some of the questions that have popped up, but we hear a lot that patients hear about having shoulder pain kind of a couple of days after the TIF procedure. Can you explain why that is and kind of how long does that normally last, if it does
Well, I know if I do a hernia repair, part of it is that when we blow up the abdomen to create space, and we use carbon dioxide to blow up the abdomen, and that we blow it up to it makes space so we can do the surgery. But at the same time, sometimes after we close, some of that carbon dioxide gets trapped in the abdomen, and you get something called referred pain, and it stimulates the diaphragm, and actually the stimulation of the diaphragm just goes to your shoulder, so patients complain of shoulder pain. Well, it takes a few days for your body to reabsorb the carbon dioxide. Average about 3 days or so, and once it starts to reabsorb, the pain goes away. But it's nothing serious. It's sort of one of the sort of unwanted side effects, but nothing serious.
Fantastic. Okay. And then, Lynn, I see a couple of other questions popping up, so I'm going to pass it back to you to ask those questions.
Wonderful. Thank you, Andrea. Dr. Lee, I loved your statement, the tincture of time, because oftentimes we don't give ourselves enough time to let our bodies adjust and heal. And so I love that advice. We have a couple questions here about medications that maybe you can answer in two of our participants in one. Loma is asking, how long should she stay on Prilosec? And Kawar has been taking another PPI by the advice of his GI and not getting much reprieve. So I guess how long should someone remain on PPI therapy before going in to see a doctor or seek a second opinion?
I would probably venture to say, sorry, I didn't hear the names, but for the second patient who mentioned that the PPI was not providing any relief or incomplete relief, that would be someone who should be evaluated by their GI physician or any physician, but ideally a GI physician, to see why they are having quote unquote refractory GERD, because that can be a multitude of things, and it may involve some of those tests that we mentioned earlier to kind of clarify what's going on. With regards to the first patient who mentioned that they are on PPI and how long, it really depends on the indication for the PPI. If there's a strong indication, some people are on it for life. But generally speaking, if they do not want to be on it for a long time, but they're getting relief from it, then they can still consider an evaluation for procedure or surgery. If they're getting relief from their PPI, but they don't want to be on it long term, then they can still be considered for a procedure or surgery.
Wonderful, thank you. I have back and stomach pain and also had heartburn after food. So it's Kawar asking, he's just not sure what to do in his situation. He's been evaluated. He's had the hernia repair. He's on the PPIs and he's still struggling immensely. So I think your advice to be reevaluated, maybe seek a second opinion, might be a good option for Kawar. But is there any specific food that you would recommend or any diet choices you would recommend for someone struggling like that?
Well, I think the general diet for patients with reflux are, things that are not spicy, things that are not too acidic. Obviously things affect others differently, but those are the general recommendations. And again, I think that I want to make sure that, if you are seeing your physicians and you're not happy or they're not able to sort of figure out what's going on, it may be you need to go to somewhere with more experience or more specialists to sort of tease out things that's going on. Because if you've had surgery already and it's still experiencing symptoms, then that's something that needs to be looked at by a physician, and it's hard just to figure out what exactly is going on by just the symptoms. The symptoms, as many things can cause the same symptoms. So we have to sort of do the different tests to understand what exactly is causing symptoms. So to me, it sounds like you may have a recurrence of your hernia, but it's hard to say for sure without any of the data.
And I think it's great advice. Just in general, we hear a lot of folks come onto these events and they have questions about what do they do. They've tried everything. And so I think the message overall is really about self-advocacy and, fighting for yourself and fighting for your health. And if that involves seeking other opinions, then make that decision to go for it. So thank you for that. Andrea, I'll turn it back to you.
Thank you, Lynn. I do see another question coming up. There seems to be a lot of questions about food and what to eat and what not. So, and I love what you guys are recommending. I mean, at the end of the day, if you're not satisfied or not getting relief from what you're currently doing, it's best to come and see a professional that can help you diagnose what's really going on. But I do want to mention, we do have a patient mobile app called GERD Help. It's the GERD Help mobile app. You can just go on your Android or iPhone and search in the app section for this. And the reason why I'm bringing that up for a lot of you that are asking questions about food is you can track your food that you eat and the symptoms that you have afterwards. And why that's important is when you do that for a week or so, you'll start to see a trend of what's actually triggering your symptoms. And then when you do come see a physician or a specialist like Dr. Skef and Dr. Lay, you can say, hey, I've been tracking this and I notice that every time I eat this is when I start getting it, or it's always at night, when I'm having these symptoms. So it's just another tool to help if you are suffering from GERD. Again, it's GERD Help app. I do want to, I think we are through with all the questions, Lynn, is that correct? Perfect, thank you. I want to give you both an opportunity, these, at the end of the day, the reason why we do these TIF talks is really to let potential GERD sufferers know that there's other options out there besides, continuing medications for the rest of your life and or having, like surgery. So I want to give you guys both the opportunity to, what would you give advice? What advice would you give to these people who are either refractory or just still suffering or have been on PPIs for years? And what do they do, right? What are the ramifications for untreated GERD? Dr. Lay, you talked a little bit about, potential to Barrett's, esophageal cancer. So whoever wants to go first, I'll let you go first, Dr. Skef. We've been going that way. Dr. Skef and then Dr. Lay.
I think I just echo with a lot of what was said earlier about patients that have been suffering with GERD should be their own advocates. They should educate themselves about their options. They should be seeking a second opinion or a specialist opinion, and then I think they should be, if they're encouraged to do so, undergoing a thorough evaluation and then sitting down and discussing their options and seeing what works best for them. So undergoing surgery may be the solution, but in some people that's not what's in their in their best interest or not what they want, but that's okay too. So I think being your own advocate, being educated about your disease process, knowing the risks and benefits of undergoing surgery or not going surgery, and understanding that untreated GERD does carry some risk factors for Barrett's esophagus and esophageal cancer. Those are all important points to reiterate.
Perfect, thank you. And Dr. Lay, for you?
Yeah, I just want to add that, even with the audience members here today, I want to applaud you guys because you are trying to be your own advocate. You are trying to understand your disease process better. You're trying to figure out, is this going to be the right thing for me? And that's hard. You've already put your foot in the door. So, everything that Dr. Skef said, holds true. I just think that if you get to a point to where surgery might be an option, this surgery or the TIF procedure or the C-TIF procedure that we both do, it actually changes people's lives and for the better. So, you can get back to a normal quality of life. So I think that it's, if you get to that point, I think that it's worth it. People have a big change in their life for the good.
I love that. Thank you. You're getting a ton of thank yous and thumbs up and hearts from everyone that are watching. So again, everybody, thank you for joining us tonight and asking your questions. Dr. Skef, Dr. Lay, thank you so much for joining us. I know that we at Endogastric Solutions, yes, we appreciate it. Obviously, everyone that's watching and asked a lot of questions also appreciate it. If you are watching and you are in the Loma Linda, California area, you can find Dr. Skef and Dr. Lay. But if you're not, you can visit gerdhelp.com. We do have a physician locator there where you can put in your state or your zip code and you'll be able to find a TIF trained physician near you. So again, everybody, thank you for joining us this evening. We appreciate it. And to Dr. Skef and Dr. Lay, we appreciate your time. Have a great evening and we'll catch you next Tuesday. Thank you very much.
Bye, everyone.
Bye-bye. Thank you for having us.